Hello! For those of you that don't know me, my name's Diana Warren and I'm a registered adult and neonatal nurse, infant feeding specialist, board certified lactation consultant and tongue-tie provider with over a decade's experience behind me. Today I want to share with you some information that's useful to know about breast or chest feeding. There's a lot of information on the slides, but the beauty of a recording is that you can repeat all of the bits that you need to and skip the bits that are irrelevant to you. I hope that you find it informative and not too overwhelming, but please do contact me with any questions that you may have. My email are on the final slides. But just before we do begin, I have some formalities to go through. Throughout this presentation, when I refer to breast or chest feeding, I am referring to human milk feeding. The terms mum, mother, woman is used interchangeably throughout the presentation and do refer to the gestational parent who is the provider or producer of the human milk. Please be advised that all work provided in this course is protected by my copyright trademark. Therefore, it is illegal to share, copy or repurpose the materials for your own commercial use or with others. You are entitled to use these materials for your own personal use. Over the course of this presentation, I aim to go over a number of things and hopefully keep it engaging without doing a death by PowerPoint presentation or feeling like we're back at school. The aim is for it to be engaging yet informative with little videos and pictures to help demonstrate the trickier parts. There's no test. If videos don't play for you though, please just copy and paste the URL into your own browser. So, by the end of this presentation, you'll be able to acknowledge the advantages of breastfeeding, understand how to position and latch on your infant, know how to assess if your infant is getting enough to eat, recognise hunger cues, understand the anatomy and physiology of the human lactating breast, acknowledge how breast milk production is made, acknowledge how to hand express breast milk, and appreciate alternative methods of feeding. It seems logical to start with the fundamentals, so why breast or chest feed in the first place? For infant health, it protects children from a vast range of illnesses including infection, diabetes, asthma, heart disease and obesity, as well as sudden infant death syndrome and many others. For the maternal health, it also protects mums from breast and ovarian cancers and heart disease. For relationship building, it supports the mother-baby relationship and the mental health of both mother and baby. Worldwide benefits. The benefits are seen in both high and low income countries, economically a financial saving personally, but also on the healthcare system. A study published in The Lancet in 2016 found that increasing breastfeeding rates around the world to near universal levels could prevent 823,000 annual deaths in children younger than 5 years old and 20,000 annual maternal deaths from breast cancer. And if being free isn't amazing in the current financial climate, both mum and baby will receive oxytocin, a hormone that genuinely makes you feel loved. Just some basics around anatomy here. As you can see, we have a human breast here labelled anatomically to the left of the slide. Areola can vary in colour and be pink, peach or varying shades of brown right through to black. It grows in pregnancy in diameter and darkens in colour, and from your first conception your body will form some little bumps called Montgomery glands, and they're with you to stay on your areola. Looking at the anatomical structure, you can see there how we think a breast looks internally, with the alveoli that makes and stores milk and ducts that transport milk to the nipple. Nipples contain many ports where the milk comes out and in many shapes and sizes, included in inverted nipples, which may or may not avert during breastfeeding dependent on whether they are tethered or not on the inside. Historically, humans as mammals had multiple nipples, ranging from the axilla to the groin areas, and to this day it's not unusual through evolution to note a mum may have a third nipple or even a mammary tissue in areas that don't have a nipple attached to it. The first stage, of course, is pregnancy. All through pregnancy, changes are happening in your breast so that by the time your baby is born, your breasts are ready to supply milk. Your colostrum or your first milk will be ready and waiting in your breasts even if your baby is born prematurely. Your breasts and nipples do not need any special treatment during pregnancy, despite this being a common practice some years ago. Natural oils are secreted from the areola so that creams and lotions are not necessary. The sucking reflex develops from around week 16 of pregnancy with the amniotic fluid, so even if your baby is born prematurely, he or she will know what to do. The areola darkens during pregnancy to attract the baby to the breast to stimulate their first feed. This usually happens in their first hour of life, but it can also be normal up to 6 hours later. Your body is incredibly clever based on the changes you're experiencing in pregnancy. Your body starts preparing to make milk. love that little video there. And that obviously has been shared with permission from the ABM, but it is also available on their website as well. So just to confirm, the letdown reflex, that's part of what was discussed there. And this is the initial surge and release of hormones, which occurs within the first few minutes at the start of a feed, which causes the milk to flow easily and stimulates your infant to drink. Some mothers do feel like a tingling sensation in the breast. They may leak, they may drip, they may spray, yet some mothers don't feel a thing, and they don't feel that letdown at all, but that is also very, very normal. Returning back to the beauty of hormones. The hormone which makes your breasts produce milk is called prolactin. This comes from a gland in your brain called the pituitary gland. Prolactin cannot do its work until all of the hormones from your placenta have gone from your bloodstream. As prolactin begins to work, your breasts will begin to fill with milk. Your breasts may feel hot, lumpy and hard at this stage and is known as engorgement, but this does settle down as the milk begins to flow and your baby learns how to feed. As your baby does feed, oxytocin is released. Oxytocin is responsible for pushing the milk up into the ducts, leading to the nipple openings. It works on both boobs at the same time, and it is the feeling loved hormone. Each time you feed your baby, the nerves around your nipple send signals to your brain to produce more prolactin. This in turn signals your breast to produce more milk. Oxytocin is also the same hormone that makes you feel happy, feelings of love, and the sense of being loved in return. There's a lot of information on this upcoming slide, but in part it's because there's a lot going on in human milk. The beauty is that it is a live bodily fluid that is constantly changing to meet your baby's needs for as long as you want it to. These are grouped here. Transfer factors. These help the infant to absorb the nutrients in breast milk. Lactoferrin is the most well known as it helps the infant absorb iron. Formula does have excessive iron in it, and much less is absorbed by the infant because it doesn't contain these transfer factors. Bifidus factor. This encourages the growth of the lactobacillus bifidus, which creates an acidic environment within the gut. Bacteria generally prefer a high alkaline environment, so this discourages bacterial growth. Enzymes. These aid digestion. Enzymes such as lysozyme discourage bacterial growth. Hormones. Thyroid stimulating hormone, insulin and growth hormone support baby's immature system to cope with life outside of the womb. Epidermal growth factors help the gut to mature and become resistant to pathogens. Immunoglobulins. Antibodies against infections the mother has previously had. Secretory immunoglobulin A coats the lining of the gut. Living with white blood cells. These are the body's defence against infection. These are made in response to any infection that the mother has been exposed to. Viral fragments. These are thought to trigger the infant's own immune system. Oligosaccharides. These are carbohydrates that prevent pathogens sticking to the gut wall. And anti-inflammatory molecules. These help reduce inflammation of the gut in response to the pathogens. It is the factor that is largely responsible for protecting babies from necrotizing enterocolitis. So what happens next? Well, milk is produced within the alveoli by the Acini cells. The myoepithelial cells propel milk along the lactoferris ducts and out of the nipple. Milk does tend to pool in the area of the lactoferris ducts behind the areola. Montgomery's glands, the bumpy bits on the areola, secrete a scented fluid which lubricates the nipple and attracts the infant. The infant would then create a vacuum to draw the milk, thus stimulating a swallow. Milk production is stimulated by the hormone prolactin, while delivery to the baby is triggered by oxytocin. Both hormones are secreted in the pituitary gland. Counterbalance is provided by the feedback inhibitor of lactation, an enzyme present in breast milk which acts to prevent overproduction. Your infant will instinctively know that he or she needs to feed when they're born, and they may take some time to work out how to do this effectively. Similarly, the birthing parent knows what to do, but may not yet have had the opportunity to try out the skill. The milk stored in your breast will not flow out of your nipples as soon as it's made. Your infant must feed effectively to get the flow going. As your baby feeds, oxytocin is released, which causes the milk to come out of the nipple, of which there are on average 5 to 14 openings. There will be short spells of strong sucking with little pauses in between. Dummies, soothers, pacifiers introduced before breastfeeding is established may interfere with the feeding ability at the breast. Breasts were around long before dummies were invented. There are some stages of production that everyone will go through. So the first being colostrum. So this is present in the body from around week 22 of pregnancy. Colostrum often looks thick and yellow, but it's packed full of nutrients. It's rich in fats and protein and is easy for your infant to digest. It also contains infection-fighting antibodies, immunoglobulins, which strengthen the immune system and protects them from infection. We then have your transitional milk, and this is when your milk's coming in. It's usually day 3 to 5 after giving birth, but it can still be considered normal if we're hitting day 8. And these delays can happen, particularly if mum's had an excessive blood loss at birth or the placenta has come out not intact, parts retained, but also some medications during labour and delivery can cause this too. We then have your mature milk. So this is when your body regulates milk and it can still be increased and titrated. Historically, breast milk was thought to come in 2 parts, but we now know that these are interchanging constantly throughout a feed and range in proportion. A mother may have more than 1 milk letdown per feed as well. So these historically were known as foremilk and hindmilk. So foremilk, or your letdown milk, comes at the beginning of a feed, but you can have multiple letdowns during the same feed. Also known as the milk ejection reflex. And it's very good for brain growth and contains important proteins and sugars within it. We then have your fattier, higher concentrated milk, also known as hindmilk. And this is higher in your fats. It gives that fuller for longer. It's great for weight gain and for the neurodevelopmental growth as well. But this is where baby's latch really is important to be effective, because they need to be able to draw that thicker content milk through. Involution is obviously the last stage, which is the posh way of saying stop. So if there is no attempt to breastfeed within the first week of life, your body does unfortunately assume that you're suffering a stillbirth. So no milk is produced at all. However, if you have attempted to put your baby to the breast within the first week of life, it takes on average 6 weeks for your breast to fully involute. But that said, there are cases of women who are still able to get random drops of milk many, many years after stopping their breastfeeding journeys. I'd just like to add in this little video here because I just think the whole process is absolutely beautiful. just gorgeous, really. And that clip was from one of my colleagues, Lucy Webber, that you may have heard online. So thank you, Lucy, for letting me share that. I could literally talk forever on the benefits of skin to skin, and I cannot emphasise how beneficial it really is to both you and your baby. Both parents can do this, as your baby will enjoy the warmth and the comfort of any adult chest, although helping to make milk is really just limited to the person that's lactating. Skin to skin contact is beneficial for both of you, regardless of how you intend to feed. If you're happy to have skin on skin, your infant will be placed on your tummy immediately after delivery. You may choose to have your infant dried first, but being uncleaned has additional benefits for your infant's sense of smell and rooting behaviours. This is your choice. It may be a good idea to be topless or have an open nightdress or shirt for the labour itself, just so that you can initiate skin to skin contact more readily. The baby can then be covered with a warm, dry towel. Skin to skin contact should continue uninterrupted for as long as you wish. It should at least go on until the baby demonstrates feeding cues and has their first feed. It also has fantastic benefits for their partners too. Promotes bonding, development, reduces crying and encourages sleep. At no other time will you or your infant have such high levels of hormones and natural nurturing instincts. However, it may not be possible for everyone. For example, if your infant is sick or extremely premature, your midwife or neonatal nurse will be able to advise on individual circumstances. But in the neonatal setting, it's quite common to have skin on skin as part of kangaroo care, which is basically skin on skin inside your top or your t-shirt, but it can also be done inside a sling. Many benefits. So it keeps the infant warm through temperature regulation. It helps calm and relaxes both the parent and the infant. It reduces crying. It releases feelings of security. It regulates the heart rate, respiration rate, and oxygen saturation levels. It encourages a close, loving relationship through oxytocin. It reduces the risk of low sugars. It boosts maternal confidence. It encourages maternal supply. Infant colonisation to parental bacteria to build your infant's immune system. Surges in oxytocin helps the uterus to contract, reducing the risk of heavy bleeding following a surgery or the delivery. Aids restful sleep and temperature regulation. Now, recognising feeding cues is a tricky one, and just to make it even more difficult for you, they all interchange with each other. So your winding cues, your tiredness cues, your comfort cues, and your feeding cues can look very, very similar. But as you and your baby learn more about each other, it does become easier. Cues can include waking up and stirring, licking the lips, sticking out their tongues, lip smacking sounds, hand-to-mouth activity, head bobbing, rooting, and the last hunger cue is crying, but obviously you do want to be aiming to feed before you get to this stage. There's a little image there of some cues that may appear similar in your case. But what I like is, if in doubt, whip them out. And that's because whatever the cue is, if they want to feed for any reason at all, bearing in mind that infant feeding is not just for nutrition, from you they will latch. But also, breastfeeding infants will not put in the effort to feed effectively if they're not hungry, which is why a breastfed baby can never be overfed. Positioning and attachment is a good one. Now, this is easier said than done, and if there is any take-home message at all to highlight from all of this, it is that if baby's struggling to latch for whatever reason, please reach out to a specialist as soon as you can. Pain is not normal in the early days or at any point, despite what they say, and we want feeds and need feeds to be comfortable, enjoyable and sustainable. There are many positions that you can experiment with, and you may even be able to make up your own. But generally, for the breastfeeder, a supportive chair is ideal, mainly for your comfort. We can look at using feeding pillows. They can be very useful in the early days, particularly if you've had a section. It can help protect your scar tissue. But it can also become a little bit of a hindrance as the baby grows because it puts their alignment out and makes them a little bit too high. Make sure that you're bringing the baby to you, not your breast to the infant, otherwise you're going to start getting backache if you're hunched over them. Baby's chin and lower lip should touch the areola first, so they end up doing like an up and over onto the breast itself. And we're aiming for an asymmetrical latch, so you've got more of your breast tissue into your baby's mouth based on their lower jaw. For the baby, they need to be in alignment, as I've already said. So their ear, shoulder and hips should be in a straight line. Now this can be at any angle, so providing they're in a straight line, they could feed in your standard cross cradle position, as you can see on the picture there, but they could also, in theory, feed upside down. It's absolutely possible and perfectly normal. As long as those points are in a straight line, then there's no reason why that wouldn't work. And here you can see we have the chin analogy here. So C being close, H is their head is free. So we want to make sure that whichever position you're holding them, you're not preventing them from extending and flexing their neck. They need to be able to extend their neck back to get that up and over on action. So they're literally chinning the boob first with their head in the extended position before they come up and over. And they need their head free to do that. Holding baby into position by their head is not going to work. It will always be shallow at that point. In line, as I've said, and nipple to nose. So you're aiming for the nipple as if the nipple's going to go up the nose while you're waiting for that nice wide open gape. And then as they get that up and over, your nipple posts into their mouth and is vacuumed to the back of their mouth. So here we have a lovely short video to visualise what I'm trying to demonstrate and describe here.
Although she began breastfeeding baby Rufus as soon as she could, Teresa needs reassurance. She has asked Nikki, a breastfeeding peer supporter, to come and make sure Rufus is feeding properly.
Rufus? I can observe a little feed maybe later. Do you think would he be ready to feed now? He might be.
Nikki explains that if Teresa's baby attaches correctly at the breast and feeds well, it will help her establish a good milk supply for the future and overcome their difficult start.
Just for attaching him, you could try attaching him in cross cradle. Do you know what I mean by that?
Is that where, I think, see it where you put your arm across like that?
Yes, that's right. And aiming nose to nipple.
Nikki shows Teresa how to achieve good attachment. Bring the baby's nose directly opposite the nipple. Let his head tip back a little so his top lip can brush against your nipple. This should make him open his mouth. When his mouth is wide open, bring him quickly to the breast with his head back and chin leading. The baby can then take a large mouthful of breast, not just the nipple. The breast will be drawn deep into his mouth, so your nipple will go all the way back to the soft part of his mouth and you won't get sore. So, once your baby's head has tipped back, your nipple will brush his top lip. Wait for the wide gape, then bring your baby quickly to the breast, chin leading. In this position, feeding will be comfortable and your baby will be able to take all the milk he needs.
So long as you've got your position and attachment right, it should be like that. It should be nice and relaxed and enjoyable.
So establishing breastfeeding does take a good 4 to 6 weeks. Nobody is expecting you to master it on that first go. Winding after each feed is important, especially until the latch is optimal, because they will drink air and that's not particularly comfortable for them either if you think along the lines of trap wind. So things to look for: chin on the breast, the lower lip is flanged. Lips need to be at around the 140-degree jaw angle. That is a loose guide though. No clicking or popping noises during a feed. They're comfortable feeds, so you have no pain at all. Rounded cheeks during a feed, not dimpling. The tongue is protruding over the lower gums. Audible rhythmical swallowing, not gulping. Softer boobs after a feed. Baby is held in close and they're in line. Don't rush, it doesn't matter if you miss the wide gape. The baby is going to reattempt to relatch, so if you don't master it first time, it's fine, they're still hungry, you just go again. A shallow latch may result in flattened or wedge-shaped nipples, cracks, bleeding, pain and poor breast drainage. Should you experience any of these, or if you're unsure, please seek support. So asymmetrical latch.
Have something better, right? Okay, so this is the positioning that we teach. Again, it's important to realize that babies don't always have to latch on this way, but this makes it more efficient and the baby gets more milk. So we ask the mother to push in here, hand underneath the baby's face. The nipple then runs along the baby's upper lip, just a tickle. Wait for that gape. Come on, you're going to be on TV, you have to do, that's right, and then straight on. There. So the baby's chin is in the breast, but not her nose. And she covers more of the areola with her lower lip than her upper lip. And that little pause in the chin, there is a mouthful of milk. Sometimes you can pull the chin down, because she's not on as quite as well as she should be. And that's even more like that. There, mouthful. Each pause is a mouthful. And you can see that on day one, that pause, if the baby's latched on properly. It's no big deal now, because the mother has a lot of milk. But that baby is getting milk and drinking well. And a baby who's doing what she's doing there for 20 minutes won't even take the second side. And if she nibbles for 20 hours, she'll come off the breast hungry. So she's resting there, but then she starts again and she gets a mouthful. And there's a nibble, nibble, and then a mouthful. Mouthful. Mouthful.
I think she's nibbling more in the evening time.
Yeah, mothers have less milk in the evening.
So it's quite a handy technique to know, which helps achieve a nice wider gape, really working the jaw, and helps with extracting the milk, full drainage, as much as we can from the breasts too. As you can see from the slide on the right, we're really looking for an asymmetrical latch, and this is really where more of the breast tissue is being worked by the jaw on the underside of the breast itself, rather than bullseye practice central. This is quite a sped up sucking action here, but it is a good demonstration, and it shows an internal side view of the baby's head. You can see the white, and that represents mum's milk, and that's being drawn through the mother's breast and released at the throat of the infant. Over the tongue is the mother's breast, which is why we want a nice wide gape so that we can breastfeed and not nipple feed, which is painful. The soft palate muscles lift to close off the nasal breathing area to create a negative pressure, which allows milk to be drawn through, creating a bolus to stimulate a swallow. The soft palate also stops aerophagia, which is swallowing of air, through closing off the nasal pharynx at the same time to allow for a swallow. How much? How often? Yes, I'm often asked this alongside, is my baby getting enough? There are times, particularly in the first few days, where your infant will appear to be constantly hungry. And this is absolutely normal. It takes an average of 4 to 6 weeks to establish breastfeeding behaviours. Baby moons. Some cultures take time just to be alone with their newborn, teach them how to latch and recognise individual baby behaviours. This involves nothing other than relaxing with your baby. Other family members or friends would come around and they'd take care of the daily household chores to allow the mother to dedicate her time to her infant. 1 breast or 2. Base this on your baby. If they still seem hungry following a full drainage of 1 breast, offer the second. Just be sure that to offer that second breast first at the next time of feeding, just to ensure it does get frequently fully drained too, rather than multiple half feeds on that one side. It is normal to need to feed during the night. It is also normal to have cluster feeding periods. Sucking patterns. There are going to be short spells of strong sucking with little pauses in between. When the milk is in, feeding is rhythmical and coordinated, and you should see signs that your infant is actively swallowing. Most newborns will want to feed 8 to 12 feeds within 24 hours, but this is variable on many factors. At the end of a feed, your infant will unlatch and appear satisfied, calm, or asleep, milk drunk. If you need to unlatch your baby before they have finished, slide your finger into their inner cheek and break the suction vacuum between their gums using the pad of your finger. Responsive feeding is a relatively new term. Some of you may know it better as on-demand feeding, but that does sound quite strict and demanding. The idea of responsive is because, yes, we want to encourage a feed each time baby wants one, but we also want to encourage a feed each time your breasts need drainage too, just so that you're both in sync with each other. Responsive feeding means allowing your infant to feed whenever he or she wants to for as long as he or she wants to. Feeding should not be timed nor set to a schedule. Try not to clock watch. Look at your infant for the sucking patterns instead. It is best to feed your infant as often as they ask for it. Soft breasts are a sign that milk production is working at its best. Feeding to a time schedule is not recommended. Traditionally, mothers were told to feed at set times for set periods. For example, 10 minutes each breast every 3 hours. For example. Unfortunately, this does not take into account developmental leaps, the different mothers having different milk types based on different diets, areas of the world, and consequently those infants were just left hungry and unsatisfied, which may have inhibited maternal milk production. Both frequency and the duration of feeds vary over time between individuals too, taking into account it is a live product. Along with effective attachment, responsive feeding is essential for successful breastfeeding. So, milk capacity and production. As a general guide, your body may produce around 750 ml to a litre from around week 2 onwards. Up until that point, it is obviously less and more in concentration than it is volume or yield. As the composition and the viscosity of the milk as a live product changes, the volume intake required doesn't need to, and this is the point when your body switches between endocrine and autocrine modes. It's very different to bottle feeding because volume intake would obviously increase with age and their ability. Milk production can vary throughout the course of the day, and the amounts are usually greatest in the morning and then gradually decreases as the day progresses. The maternal prolactin levels are the highest between 2 and 4 a.m. So if you really need to increase your supply, feeding or expressing during the small hours is going to be the most productive. A mother's storage capacity is the amount of milk that her breast can hold in between feeds. It is not related to the size or the total volume of milk that a mother can make each day. And this is demonstrated a lot better on the infographic just to the right of the slide. Recognising when feeding is going well. This is handy to know and can be reassuring if you have concerns. So the first thing would be looking at their weight. It is normal to initially lose weight following birth and can take a couple of weeks to regain their birth weight, but then a steady gain would be expected, but your midwife and your health visitor will monitor this for you. Then we'd be looking in terms of infant behaviour. Are they alert and active? Are they waking for their feeds naturally? You're not having to wake them up to remind them to feed. Frequency and duration of feeds. This is usually in the realms of 8 to 12 times per day, but developmental leaps and hot weather can increase the frequency and in terms of cluster feeding as well. The feeding behaviour after a feed. Are they content? Are they settled and milk drunk after a feed? And then of course nappy output. So this is going to be the easiest one for you to monitor. So the first few days in terms of urination, the nappy output isn't going to be too great, but that is expected to pick up after around day 3. But do discuss concerns about nappy output with your midwife if you're concerned. And then moving forwards in terms of stalling, we should be stalling at least every day until around the 6-week mark, but preferably multiple times a day as well. In terms of stalling on day 1, you are looking at having that meconium type poo for baby. And then moving on to day 2, the dark green khaki colour transitional stalling. Day 3 can be quite green and brown, but a bit looser in consistency. Day 4 is more your Korma style coloured stalling, so that yellow to brown, before moving on to day 5, and this is your mustard, English mustard coloured stalling, and it can be quite seedy when baby's receiving human milk, and frequent too. With regards to urination, you can get urates in the nappy, particularly if baby's not getting enough fluid in. So sometimes urates is known as brick dust or pink crystals, and these can be a sign that your baby needs a little help just to feed a little bit more often or more effectively, just to increase that intake of volume, and this prevents dehydration. And that's just a little photo example of what they can look like. But also in females, it's also normal to have signs of vaginal bleeding or spotting in the nappy, lumps to the breasts or white stringy mucus from the vaginal areas. Now this is related to the maternal hormones that have been passed through at birth and is not expected to last very long, but please do discuss this with your midwife or your GP, particularly if you feel it is excessive. Potential issues. Yes, there are things that can happen to keep an eye on, as there is with everything, but the key is to access support as soon as you can. There are many issues associated with breastfeeding, but nearly every single one of them are a result of an inefficient latch. So the key really is to master the latch. And that's not always down to mum, that can also be down to baby. It's about working together as a dyad. The early days are not always plain sailing. Both of you guys have got to learn, but once the skill's learnt, it is so much easier. Some of the issues included in what I'm talking about is a low supply, a tongue tie, thrush, blocked ducts and blebs. Now these things can lead to mastitis or an abscess, inverted nipples, weight gain or weight loss in both mum and baby, cleft lip or palate, allergies, jaundice, insufficient glandular tissue or tubular breasts, pain, reflux, or a fast or an oversupply. But should you have any queries, questions or concerns with any of those listed there, or any additional ones breastfeeding related, do seek support. There are feeding groups and cafes that are free to access, and there are private options too. Be prepared in pregnancy, find out where they are before you give birth. But regardless of the feeding challenges that you may face, please, in order of priority, protect your supply. That way that you have got options open to you, whatever happens. Feed your baby. Obviously, we don't want a starving baby, so that's not the aim of this at all. And then address the issue. We need to look at the root cause of what's going on, so then we can get back on track. Maternal health. There are very few reasons that a mother would be unable to breastfeed. Many mothers assume that they have a little or a low supply, but this is in fact incredibly rare, although possible, but it is usually a physiological response to an ineffective latch for whatever reason. Very few medications are contraindicated for use due to the transfer into breast milk too, for example chemotherapy, although most patient information leaflets found in the medication boxes will state otherwise, but this is usually because it's unethical to test them on pregnant or breastfeeding women. Your GP or pharmacist will be best to advise. If you look to the right of the slide, we have the breastfeeding network. Now that is headed up by a whole team of breastfeeding specialists that also specialise in how medications transfer into breast milk. If you look them up on Facebook and send them a message, they will more than happily tell you what's contraindicated, what can be used, when not to use them. They're very, very helpful and a good parental resource. They are charity run, so it is free, although they would like a donation if you can, but otherwise it is free. Most hormonal related conditions can affect breastfeeding too, because breastfeeding is a hormonal response. But many of these are managed with some additional knowledge. These things can include diabetes, thyroid conditions, or fertility issues. Polycystic ovaries are all examples. It is also a good idea to be aware of your own mental health. There are lots of support agencies out there available locally to you, but should you, your family, or your friends have any concerns, please do seek support as soon as possible. Your GP, health visitor or midwife are all a good source to point you in the right direction of where to access this support. This comes up in just about everything, doesn't it? But it's not all doom and gloom, it's more about being responsible and safe. So cigarettes and alcohol. Breastfeeding mothers can have occasional small amounts of alcohol, but it's more the regular or your heavy chronic alcohol drinking that's not recommended. Smoking whilst breastfeeding is not advised. However, the benefits of breastfeeding and smoking are still greater than formula feeding. Smoking after a feed and away from your infant is suggested just to limit your infant's exposure to secondhand smoke, and preferably outdoors if you can. Please also consider that secondhand smoke inhalation from other members of the household. Bed sharing, co-sleeping and falling asleep on the sofa or the armchair are not safe practices, particularly if you drink alcohol or smoke or are a recreational drug user or take medications yourself, such as sedative prescription medications. Contraceptives. Probably the last thing on your mind right now. However, it is worth knowing that many methods of contraception rely heavily on hormones to prevent conception. By default, this means that many forms of contraception will impact on your maternal supply, which is also hormonally driven. The progesterone-only contraceptive pill is believed to have little or no impact, although more studies are required to prove this, as many mothers do report a dip in supply when using it. The lactation amenorrhea method, it's a type of contraception, a natural form, that breastfeeding mothers can use and consider using nature's way of spacing time in between further pregnancies. It's believed to be highly effective, although there are conditions to ensuring its effectiveness. These include that your menstrual cycles haven't returned yet since the birth, that the baby is breastfeeding exclusively, day and night, without any long breaks between feeds, and that no artificial teats have been used at all since birth, and this is inclusive of dummies and bottles. And also that the infant is under 6 months old. Premature babies tend to have a bit more of a rough ride on the start of their feeding journeys, as there may be an impact on mum's milk-making development in the latter stages of pregnancy, and also regulating the suck, swallow, breathe reflex for baby. But it really does depend on the individual, and again, access to skilled support is absolutely vital, as human milk has so many protective factors within it. A term infant is a baby that has been born between week 37 and 42 gestation. Earlier than this is classed as a premature infant, and that is broken down into 3 further categories. We have the extremely preterm baby, which is a baby that's less than 28 weeks in gestation. We have the very preterm baby, which is week 28 to 32 of gestation. And we finally have the moderate to late preterm baby, which is 32 to 37 weeks. Now, there is a condition that's known as necrotizing enterocolitis, and this is a condition of the bowel that can affect premature infants. It is more associated with formula feeding, but if the infant doesn't respond to treatment, it is a condition that can be fatal. Breast milk, however, is better for the premature gut and the digestive system, as it's easier for them to tolerate and digest. Breast milk also contains proteins and antibodies to protect the baby against infections. We do also categorise some premature babies based on their birth weight too, with regards to how more at risk they are or susceptible, should I say, to other infections. So there are birth weights. So we have a low birth weight, and this is defined as a weight of less than, but up to and including 2.5 kilos, irrespective of the gestational age. However, a very low birth weight can also be less than 1.5 kilos, and then we have extremely low birth weight infants as less than 1 kilo. Jaundice. Another infant condition that's extremely common, and ideally we want to clear it through efficient feeding to get volume in, but sometimes that's easier said than done. All newborns appear to have some degree of jaundice in the very early days, and there are different types, but the more common one is physiological jaundice, and typically this begins on the 2nd or 3rd day of life. Prompt action to prevent deterioration and prolong jaundice is key, and it's reliant on efficient feeding. Your infant may be too sleepy to feed, so you may need to encourage them to feed, and this is usually around the 2 to 3 hourly mark as a minimum. Frequent skin-to-skin contact is suggested just to help facilitate breastfeeding. If your infant is jaundiced, your midwife will be monitoring them closely, so do speak to your midwife if you're concerned. They tend to assess the bilirubin levels either from a monitor called a bilirubinometer, which is a light test against the chest and the skin, or it could be for a blood test at the hospital. But this will guide you should any intervention be advised. Weight loss of your baby is expected in the first few weeks of life. Your midwife and health visitor will monitor this and advise you accordingly. It is common for babies to lose weight in the first few weeks of life. Babies are not usually born fat, and usually what happens is it's just the additional fluid that they've ingested during the birth, and then they've passed it out as wee. If you've received intravenous fluids through a needle in your hand during delivery, they could have absorbed all of this fluid too. As a precaution, your midwife will monitor the weight loss and be able to assess should there be any concerns. The weight will be plotted in a chart in your infant's red book or on the e-red book. There are other causes to be mindful of though, and this includes inefficient milk intake, illness or infection of the baby, or inaccurate measurement. Weight is monitored and plotted in special graphs in the child's red health record or electronic record. If your infant is losing weight and your healthcare professionals are concerned, the latching and positional aspect of breastfeeding should be checked as a priority, and a feeding plan will be discussed with you. Vitamin D. This is a vitamin that is commonly overlooked, and most of us, even as adults, are deficient in it. Everybody should be taking a vitamin D supplement. Vitamin D deficiency in the UK is a consequence of our weather and the latitude in which we live. Adults are advised to take 10 micrograms per day, but because the dose varies in accordance to the climate that you live in, this dose is only relevant to those living in the UK. Advice from Public Health England changed in 2016. All babies need supplementing from birth, regardless of how they are fed, between 8.5 to 10 micrograms per day. However, infant formula, if the baby is having over 500 mils in a 24-hour period, it is fortified with vitamin D, so supplementation is not necessary unless there is a further deficiency. If you're under 18 or in receipt of universal credits, you may be entitled to the Healthy Start vitamin drops and food vouchers. In some areas, Healthy Start vitamins are free to all families, but do check this with your health visitor if whether they're free where you live. Just to confirm, all babies, including breastfed babies, should be given a daily supplement of vitamin D. They should be given on a teaspoon, purely because droppers are quite hard to sterilise, and Healthy Start vitamins remain an excellent economic source of vitamin D, and some areas get them for free. Maternal diet. What can you or can't you eat when you're breastfeeding? But unlike during pregnancy, a breastfeeding mother can eat and drink most things, and there are not any specific foods that you need to avoid at all. It's advisable to have a nutritious, balanced diet because that's healthier for you, for your milk supply, and perhaps even your infant's food preferences in the future. You may drink to quench your thirst. You don't need to drink an excessive amount of fluids to aid your milk production, as a lot of the older texts do suggest. It's not advised to aim to lose weight yourself whilst lactating, as your body needs the calories to produce the milk. Do keep an eye on your caffeine intake though, as excessive caffeine can pass through into your breast milk. A few cups is absolutely fine, but just bear in mind that caffeine isn't just present in coffee, it's also in many fizzy drinks and other hot beverages too. Sometimes a mother may need to do an elimination diet just to rule out allergies. This is a little bit different to the diet itself. The most common allergy though that we see in infants is a dairy allergy, although it's not necessary to do this unless your infant is displaying the symptoms of cow's milk protein allergy or other. Lactose is present in all mammalian milks, and it's incredibly rare to have a lactose intolerance to your own mother's milk, but too frequently lactose intolerance and CMPA are confused. Making milk yourself though also uses up calories. Some mothers may lose weight whilst lactating, some after they've finished lactating. Some don't even lose weight at all. However, when you're exclusively breastfeeding, it is recommended that you have an additional 200 to 500 calories per day. What do you need to buy to prepare for your breastfeeding journey? In essence, nothing. However, dependent on how your feeding journey goes, some mothers find some things can be useful. Obviously, you're going to need your breasts. Nursing bras are practical. It is important to be remeasured as often as your breasts will change size. Find a good, supportive but non-wired bra. There are specialist fitters for both pregnancy and breastfeeding out there. Knowledge is power. So not technically equipment, but particularly useful. Especially on how breastfeeding works and expressing, particularly hand expressing. Some mothers may choose to use a manual or an electric pump. The world is your oyster. Double electric hospital grade pumps though are known to be the most efficient, and they can be rented directly from the manufacturers to help prevent having to pay out for full cost. Do know in advance where you can buy spare valves and other parts from, as some do need replacing every 6 weeks just to ensure efficiency. Also note that high vacuum pressure on electrical pump does not equate to the more milk yield that you make. The vacuum needs to be comfortable to you, and it's only variable because all mothers are different. Sometimes nipple shields can be a useful temporary tool, although if you feel you may need to use these, it would be best to seek professional support too, just to identify why you need them and address that issue directly instead. Nipple shields do come in different shapes and sizes, and the shape is to reflect the infant's palate, and the length of the teat is to ensure that it reaches the infant's sucking reflex. It is not that we want your nipples to be that long. A nipple shield can be a handy tool for a mother to have, but if you need to use one, do address why you need to use one with a skilled lactation provider. You might need a sterilising kit if you're considering expressing particularly. There are many options available these days, including microwavable, UV, electrical steam, or even cold water tanks using sterilising tablets or liquid. Creams and drying agents are not recommended, but some mothers do find that plain white petroleum jelly is helpful, but there's no need for any form of nipple preparation in pregnancy. Do attend some infant feeding support groups just to familiarise yourself with surroundings in pregnancy. Getting to know the staff, the volunteers, knowing what days and times they run, the venues, some are term time only, for example, and many are supportive of you attending even during pregnancy. So as I've said, expressing is a very useful technique to learn, whether it's hand expressing, manual or electric. There are different reasons to express and may include increasing your supply, managing a fast flow, or even clearing a blockage. During pregnancy, antenatal hand expressing, or sometimes known as colostrum harvesting, is not advised before week 37 gestation of your pregnancy, as it may induce an early labour. You may collect this colostrum in 1 ml syringes, which you can buy very readily, sterilised individually on places like Amazon. And these can be given once your little one is born as either a feed or even just for mouth care. This can be particularly useful if you're diabetic or suddenly taken ill or require a general anaesthetic so that your infant can still have breast milk colostrum. When a newborn is particularly sleepy, a few drops may be suggested to stimulate or encourage a healthy baby just to become interested in a feed, just to wet the whistle, so to speak. Expressing breast milk is also a useful skill to have when feeding's not quite going to plan, to increase your supply or to save up for and use at a later date. If your breasts are not fully drained after a feed, you are at risk of blocked ducts and mastitis, but your body also believes that the milk is no longer required, so then milk production begins to dip. So expressing after an inefficient feed is also suggested. But how to hand express? Cup your breast with one hand and then with your other hand form a C-shaped shape with your forefinger and thumb. Squeeze gently, keeping your finger and thumb a few centimetres away from your nipple, just outside the darker area around it, the areola. Try not to squeeze the nipple itself, as you could make it sore. The whole process shouldn't hurt, but do release the pressure, then repeat, building up a rhythm. Try not to slide your fingers down the breast or over the skin. Drops should start to appear, and then your milk will start to flow. If no drops appear, try moving your finger and thumb slightly, but still avoid squeezing the darker area near your nipple. When the flow slows down, move your fingers around to a different section of your breast and repeat. When the flow from one breast has slowed, swap to the other breast and keep changing breasts until your milk drips are very slowly or just stops altogether. Talking about how to hand express really does make it sound quite overcomplicated. So here's a short clip just to help put it into real time.
The UNICEF UK Baby Friendly Initiative recommends that all mothers are shown how to hand express. This is a useful skill which can be used in the following situations. Expressing small lots of colostrum to tempt a sleepy baby in the early stages of breastfeeding. When breasts are full, making it hard for babies to attach. To help clear a blocked duct. Or if you are separated from your baby, for example, if your baby is on the neonatal unit.
So when you're hand expressing, start off by doing anything that relaxes you. So having a cuddle with your little one, skin to skin, a bit of massage, anything that helps you relax. So sometimes it could be kneading around the breast, sometimes it's stroking, whatever feels right, whatever feels comfortable to you.
If expressing for a premature baby, massage is important to ensure a good milk letdown. However, if just expressing to soften your breast, just a small amount of massage may suffice.
Once you've done that for some time, if you make a C shape with your hand, with your thumb and finger, gently feel back from the nipple, about 2 to 3 centimetres. Hold it for a couple of seconds and then release. And then just compress, hold and release. Now in the early days with colostrum, this won't come straight away, it can take some time. So just keep working that one area. It will appear as little beads. As the milk comes in, you'll see it will flow much more easily. Sometimes you might need to move forward a little bit, sometimes you might need to move back a little bit. The main thing is working that one area until it fully subsides. And then what you can do is rotate round the breast and work on the next area, compressing, holding and releasing. So the key thing as you're doing there, you've kept your fingers right in the right place, that's perfect. And the key thing is you're doing that compression right where your thumb and finger are, and you're making sure you're not sliding, and that's really important. When you slide along the skin, it's not as effective and it can also cause a bit of trauma to your skin. So working in that one area, keeping that thumb and finger opposite each other is just perfect.
Ask your midwife or health visitor to talk you through how to hand express. If you are expressing for a baby who is in the neonatal unit, try to express close to your baby or have a photo or a piece of baby's clothing to hand, as this will help boost your milk-making hormones.
Some women do find it easier to express milk by hand, especially in the first few days or weeks. It can also mean that you can express without needing a pump or an electricity supply. Hand expressing allows you to encourage milk to flow from a particular part of the breast as well. This may be useful, for example, if one of the milk ducts in your breast become blocked. Hold a sterilised feeding bottle or container below the breast just to catch any milk as it flows. Some mothers find gently massaging their breasts, as you saw in the video, before expressing encourages their milk to have that initial letdown. Sometimes, in infant's absence, a photo, a blanket, or something that can remind you of your infant that entices your senses, smell, vision, may also help with the flow. This is an important one. So guidelines do differ slightly dependent on where you are in the world and what you read, but also the environment itself. For example, if you're on a neonatal unit versus at your home. If you are in a hospital environment, you must follow the hospital recommendations. Otherwise, recommendations for when you're at home in terms of how you can store breast milk needs to be in a sterilised container or in special milk storage bags. They can be kept in the main part of the fridge for 5 days at 4 degrees Celsius or lower. For 2 weeks in the ice compartment of the fridge. Up to 6 months in a deep freezer, but that must be less than 18 degrees Celsius. Breast milk that has been cooled in the fridge can be carried in a cool bag with ice packs for up to 24 hours. Storing breast milk in small quantities will help avoid waste, and if you're freezing it, it is a good idea to label and date it first. Defrosting frozen breast milk. It's best to defrost frozen breast milk very slowly in the fridge. If you need to use it straight away, then you can defrost it by putting it in a jug of warm water or holding it under a running warm water tap. Once it has defrosted, give it a gentle shake just in case it's separated, but try not to refreeze the milk that has been defrosted. Defrosted breast milk must be used within 24 hours of removal from the freezer. Warming breast milk. You can feed express breast milk direct from the fridge if your infant's happy to drink it cold. Or you can warm it to the body temperature by putting the bottle in a jug of warm water or holding the bottle under running warm water. Don't microwave to heat up or defrost breast milk. This can cause hot spots which can burn your infant mouth and break down the proteins in it. Using a dummy is very much parental preference. There is research both for and against them, but we do know that in the early weeks, particularly dummy or pacifier use can interfere with supply and production. I would ask yourself why you want to introduce one. There's no right or wrong answer to this, but if it's for comfort, boobs were designed to provide infant comfort long before dummies were ever thought of. Similarly though, they can be a good tool, particularly for things like developing non-nutritive sucking skills. It is normal for an infant to want to get comfort through sucking, particularly at the breast. This is one of the many benefits of breastfeeding. When a lactating woman is tired, she releases a hormone called melatonin. This hormone passes into her milk to help her infant feel tired too. Sucking a teat is very different action to breastfeeding, as the tongue and the oral cavity is used in a different way. If a dummy or bottle is introduced within the first 4 to 6 weeks, this can make breastfeeding a little bit more tricky to establish, and it has been known to shorten the breastfeeding journey. Even small amounts of formula may significantly reduce benefits of breastfeeding, and this is known as the supplementation trap. Adoption and surrogacy. Yes, the body is amazing. You can produce breast milk even if you're not the biological mother. Breastfeeding has benefits for both the infant and the breastfeeding mother, even if they've not carried them right from conception. Worldwide, it's not uncommon for other females in the family or other villagers to share the workload and breastfeed an infant that isn't biologically theirs, or wet nursing. It's not a new concept. Queen Victoria had a wet nurse for all of her 9 children. An adoptive or intended mother can get ready to breastfeed as soon as she decides she wishes to adopt or when her infant arrives. The amount produced, though, can vary widely. Some manage to exclusively breastfeed, others do require supplementation, but this can still be done at the breast using a nursing supplementer, even if the supplemented milk is formula. Newborn babies are wired to breastfeed, but older infants such as toddlers can also learn. Some mothers do take medications or herbal remedies to help increase supply, called galactagogues. There is no evidence that these work, although many mothers do believe that they help. The key to increasing or commencing a milk supply is through breast stimulation. Stimulation can include skin to skin, suckling at the breast massage, or hand and pump expression, and it is applicable for all breastfeeding parents. And for twins, triplets or more, your breasts are designed to feed multiples. That's why we have 2. Frequent emptying of the breast increases your supply naturally to accommodate for multiples. Soft breasts are good breasts. It is not recommended to limit to 1 breast per baby either, due to feeding ability, technique, maternal supply flow. They're all individualistic. Multiple births are at an increased risk of prematurity, so there are additional benefits for the infants who breastfeed. Your breasts will be able to provide a specific milk to feed a premature baby and prevent them from serious illness. Twins Trust is a UK-based charity that helps prepare parents in pregnancy for the births that they are expecting. They offer courses and webinars too. Tandem nursing refers to feeding 2 or more infants during the same period of lactation. For example, a newborn and an older sibling. This is perfectly safe to do, and your breast milk will change accordingly. You can also breastfeed an older sibling through your pregnancy, although it is thought that the taste does change for them at around the 5 to 6 month period of pregnancy, and the maternal body will prioritise getting ready for the unborn infant. Many women worry that they won't have enough milk. However, there are very few women that don't. With 2 infants, more milk is removed from the breast, and so production is increased. Safe sleep is an important aspect that you need to be fully on board with in order to make informed choices on how you'll manage sleep for you all as a family.
Baby Sleep Info Source, where babies sleep. This video covers the risks and benefits of common places babies sleep at night. Around the world and throughout history, babies have slept close to their mothers. In fact, until inventions like incubators, baby formula and cribs, babies could not survive without their mothers, and they are born expecting somebody to always be nearby. But in the 21st century, what our babies are expecting and where we put them to sleep can be very different. This is not something we often think about, but perhaps we should. Some babies are placed to sleep in a room on their own, but it is important to know that having your baby sleep near you during daytime and at night reduces the chance of sudden infant death syndrome. Keeping your baby's cot in a room with you at night for the first 6 months is a key way to keep them safe. Many parents find that night times are easier when they share a room with their baby. Nighttime feeding is easier, babies cry less when close to their parents, and both parents and babies get more sleep. For some babies, night waking goes on for the whole of the first year. Many parents bring their baby into their bed to sleep, but for most babies, this is not where they always or usually sleep. Bed sharing mostly happens for part of the night or for a couple of nights a week. About half of all UK babies will have bed shared by 3 months of age. Bed sharing has advantages and disadvantages that parents need to know. It is closely linked with breastfeeding. Up to 80% of breastfed babies sometimes sleep with their mother or parents in the early months, and studies have found that mothers and babies breastfeed for longer if they bed share rather than if they sleep apart. Other reasons that parents bed share are to help bonding, to monitor an ill baby, or perhaps because they cannot afford a cot or Moses basket. It is important to know that there is a link between co-sleeping and sudden infant death syndrome, particularly if one or both parents smoke, have consumed alcohol or drugs, if co-sleeping happens on a sofa, or if the baby was premature or had a low birth weight. Falling asleep on a sofa and bed sharing if you smoke, take drugs or have drunk alcohol can be very dangerous and might happen accidentally. So it is important that parents know about co-sleeping and bed sharing safety, even if they don't plan to do it. Remember, think carefully about your baby's safety for every sleep and be sure they are in a clear, flat space. Thank you for watching this video. For more information and for more videos, please visit our website.
Using breastfeeding to entice your infant to sleep can be a helpful and biologically natural and normal tool, but many parents are told not to. When a lactating mother is tired, she releases sleep-inducing hormones into her milk that pass on through to her infant, both naturally and normally. Regardless of your sleeping arrangements, your infant should remain sleeping in the same room as you until at least 6 months old. Preferably, your infant should be placed on their back on a firm surface with their feet closest to the bottom of the crib or the bassinet or the cot. Bed sharing is popular and many infants will not settle to sleep using any other method, but it is vital that if you do so, you do it safely. Your partner is important too. Partners, family members and significant others can bond in many ways, such as bathing, nappy changes, skin to skin, baby massage and of course lots of cuddles. Your partner can help check your infant's latch for you to feed. Your partner could undress your baby ready for a feed or skin to skin time. Can be encouraging and reassuring to yourself as the lactating adult, in both supporting both the mum and the infant, of course. Chest feeding at the chest, usually with dry nursing supplementer, should they wish to give milk this way, or with artificial hormones. A biological male can still feed their infant themselves. Or dry nursing. This is breastfeeding where no milk comes out, and can be anybody really in essence, but the baby still gets comfort from the sucking action. It is more important to establish breastfeeding for yourself though than it is to play host to visitors and everybody else who wants to come along and have a cuddle with a newborn. As well-meaning as this is, it can hinder the breastfeeding relationship, as new textures, sensations and smells are all new to the infant, and it is not as reassuring to them as the comfort of the parents. They've been familiar with your voices since conception. And this area is known as the 4th trimester. Really, the ideal way that a family member or a friend can help would be to assist with cooking meals and doing your household chores for you. That would then free up your parental time so that you can spend your extra time with your baby. There is nothing more important in the world than your infant learning to feed. Teddies from work colleagues really can wait, as can cleaning the house. And as well as a partner, there's a wider community of support out there. It will be specific to you, but it may include each other, friends, lactation consultants, social media support groups, local infant feeding teams, breastfeeding helplines, your midwife, your health visitor, your partner, breastfeeding peer supporters, the mums that you meet at groups such as feeding cafes, mummy meets, stay and play, all of those different groups that you can get into. Your wider family, breastfeeding support groups, or your GP. There are a number of ways that you can feed your baby. Breastfeeding can be all or part of it. You don't need to make that decision immediately because your choices vary from day to day based on lots of different things. In some cases, other methods of feeding are either necessary or choice. The most common method of alternative feeding is bottle feeding, but other methods may include cup, spoon, or syringe feeding. Breastfeeding takes a good 4 to 6 weeks to establish, and so the introduction of these alternative methods are discouraged because they can be responsible for infrequent breastfeeding, which can cause your own supply to falter, increase the risk of engorgement, delay your own milk coming in, and alter the infant's sucking patterns. Occasionally, a breastfed baby may have a medical need for additional feeds, such as ill health, weight loss, jaundice, or prematurity. Do maintain and establish your own supply though through breast stimulation and skin-to-skin contact. Use your expressed breast milk where possible, or donor milk's also an option when it's been sourced reliably. Try the first several feedings of colostrum for gut maturations where you are able. Evidence shows us that the earlier a dummy or a pacifier is used, the shorter the overall duration of breastfeeding is. And there's more to think about than just standard breast or bottle these days, especially as it's not uncommon for a baby to refuse either method. But starting with your milk type, obviously you could use your own expressed milk, donor milk, or even formula. And there are lots of different types of formula out there, but UK law ensures that the ingredients within formula are within set guidelines. This means that they're all relatively similar to each other. Specialist formula would be prescribed, usually for health reasons of the infant. Anti-colic and reflux or anti-constipation milks are generally harder for the gut to digest and more of a marketing ploy from the formula company themselves. Try to avoid using things like the Perfect Prep machine, as they don't make the formula in accordance to the formula manufacturer's guidelines. Bottle teats. These are need to reflect the infant's palate's shape where their suck reflex is, which is one of the reasons why there are so many variations on the market, because every baby's suck reflex at different ages and stages of growth is going to be in a slightly different area. So don't go out and buy the whole birth to toddler range of one particular brand. Cup feeding. Your healthcare professional can help teach this, as your infant needs to be held so upright that they lap up the milk with their tongue, similar to what a kitten would. The cup itself should not be tilted. Syringe feeding, very common in the early days, particularly with colostrum. Tube feeding, different methods on tube feeding. This is usually done by a healthcare professional though, particularly if your infant's sick. Finger feeding using a special tube is also an option though, and does encourage sucking strength. And then an SNS. This is a tube at the breast. The infant would feed at the breast in the usual way, but with an additional tube to deliver additional milk. Now this is ideal if there is a very low or no maternal supply, because it encourages breast stimulation whilst delivering milk in volume. And commonly nipple shields. These are a silicone style teat shape that can be placed over your nipple so that the teat itself stimulates the suck reflex. They're relatively cheap to buy and easy to use if you have been correctly sized for them, because they do come in different shapes and sizes. This is a common concern for mothers who assume that as soon as baby gets teeth, it's game over for breastfeeding. And it really isn't supposed to be like that. When an infant is feeding, their tongue should protrude over the lower gum line. This prevents the infant from actually biting into the nipple with that grip. However, if an infant's not feeding properly, or they're playing or fussing at the breast, then they do have that ability to nip you. And it does hurt, but believe me, they don't mean to, and they don't understand that it hurts you. If your infant does bite, there are a few suggestions to try, but ideally ruling out the root cause of why they're biting you in the first place is the best place to start. Your chosen lactation specialist will support you with these. Breastfeeding in public. This is something that really does depend on personal preference and your confidence and your own self-esteem. But either way, it's a unique choice to you and has absolutely nothing to do with any onlookers or anybody that's got a different opinion to you. Have a look at this.
As it stands, so Britain has one of the lowest breastfeeding rates in the world. However, Kate, I do think the breast is best sort of statement is out there. We are aware of that. So what's going wrong? Why aren't we doing this properly?
Well, I was shocked when it was brought to my attention that our breastfeeding rates were some of the lowest in the world. Because you think, come on, we're pretty kind of ahead of the curve when it comes to health generally, globally. And you start digging down and you realise that there is this big message out there, which breast is best. But when you get into it, actually, there is a grave lack of support for breastfeeding mums. There was a lot of funding that was cut in 2015, and there are mums up and down the country having issues, and we talked to a lot of them in the film. In the film, actually, we talked to lots of people that obviously work in this space, and generally kind of Emma Pickett, who is kind of a leading figure when it comes to breastfeeding, says that ultimately that breast is best message. The fact that we're going so strong in the hospitals, sending moms home with it, but then not providing that support is essentially a bit inhumane, you know, because women do need support. It's not easy. I thought I was just going to kind of waltz through it. I expected it to be easy. No one warned me that it was going to be really challenging.
Well,
and I had
several experiences sort of in public, one being on a tube, in fact. But in the documentary, we see you breastfeeding in the street, and you were really quite horrified at the reaction you were getting from people just walking past.
Absolutely. I mean, I want to top it all by saying what is lovely when you're breastfeeding in public is you see these mums in the distance who just give you the most compassionate, lovely smile because they feel it. They've been there themselves. But it's funny in this country, you know, whether it's a raised eyebrow or someone goes as far to say, have you never heard of a bottle? Or perhaps you should consider feeding in the toilet. Which these are all things that I've heard from the girls that we've spoken to making the documentary. I mean, that is ridiculous. Yeah. You couldn't go and ask someone in a cafe to go and eat their lunch in the toilet. So, you know.
Well, I mean, the law is in place to allow a woman to breastfeed anywhere she wants. Ironically, apart from the House of Commons.
Yes, there are a couple of areas in Parliament where you are not allowed to breastfeed. That has got to change. And what's more, we've got to have leadership in government around the issue. So at the moment, no one really takes care of this, but it needs to be included in someone's remit. So we work towards it. Scotland announced yesterday that they're adding more funding into breastfeeding. Their rates are better than ours already in England.
Yeah.
So they're investing more in it, and it's about time that we did in England.
So it is facilitating, it is, as we can talk about it beforehand, but then it comes to the practicalities of it. We have to make it simple and where you don't feel embarrassed. But I suppose then with a slightly different viewpoint, I have a lot of friends, and I've spoken to lots of them, particularly at the minute, about breastfeeding, and I have friends who just couldn't do it for whatever the reasons were. And when they then reach for the bottle with formula, they feel they're being judged by other mums for not breastfeeding. So it sounds like no one's happy within this argument.
Oh my goodness. I mean, this is what you hear all the time. Just the guilt and the shame that surrounds this whole issue of feeding your baby is insane, you know. And it would just be lovely if women could all come together around this issue, whatever you feed your baby. I mean, we made this documentary for the 80% of mums out there that want to breastfeed and start, but then for whatever reason, that drops off quite quickly in the next few weeks. And I think by the time we get to 6 months old, only 1% of babies in this country are exclusively breastfed. So it's about looking at, okay, so these women have chosen to breastfeed, so let's see if we can help them achieve what they've chosen to do.
Yeah, absolutely. Well, we did a poll as well online. We asked you, have you ever felt embarrassed breastfeeding in public? 47% of you said yes, you had. 53% of you said no. Sort of fairly even, but it's still too high, isn't it? That's far too high.
It shouldn't be unusual to see someone breastfeeding, and you should see people breastfeeding on public transport, and that'd be fine.
You think about soaps and things, you never really see it unless it's part of the narrative of the storyline. It's maybe we just need to do that more. We need to see it on our screens just more, and then no one even notices it anymore.
Absolutely. And I just think, well, do you know what a great thing we've done with this little documentary is that it's half an hour of lots of women breastfeeding, which is a rare sight. You don't see it very often.
Yeah.
I'd be breastfeeding right now if my little baby wasn't, oh, he's asleep with the dad. With his dad. Over there.
Very good. You're like a little breather, aren't you? But like we say, Breastfeeding Uncovered is tonight, Channel 4 at 9 p.m. It's so interesting, Kate. Honestly, you're very good in it as well.
Best of luck to you.
Thank you.
Your baby.
It is all ahead of me.
You just look fabulous. Utterly glowing. Utterly glowing.
That's very kind of you. Thank you.
The bottom line is simple. Your baby needs feeding, and that takes priority over what anybody around you may or may not be thinking. The reality is that when your baby is latched on and feeding, their head is larger than your nipple and most breasts, so any onlookers can't see anything anyway. However, that doesn't stop many women feeling self-conscious, and it is normal to feel that way. Until you're confident to do it, go to public places with your partner or a friend for support. Things like breastfeeding covers are available, but most babies don't like feeding under a cover and can make them too hot or uncomfortable. I certainly wouldn't like to eat my dinner under a billow cloth. In England and Wales, the Equality Act does state that it is sex discrimination to treat a woman unfavourably because she's breastfeeding. In Scotland, as you heard, breastfeeding is protected by the Breastfeeding Scotland Act, under which it is a chargeable offence to stop somebody in public from feeding their baby. The bottom line, you should never be made to feel uncomfortable about breastfeeding in public, and it's illegal for anyone to ask a breastfeeding woman to leave such a public place, especially a cafe, a shop, or even public transport. This can be tricky dependent on your working environment. Many mothers are still breastfeeding at the time they return to work. Do speak to your employer before your return to work to discuss what options may be put into place for you. If you're unsure, some employments do offer keeping in touch days or kick days, which may help you decide which option is the most practical for you as your family or dyad. Some options to consider is if your childcare provider or a nursery is close to your workplace, you might be able to visit during the day. You might be able to work from home or flexible working. Your care provider bringing the baby to your workplace on set break times. Or you could choose to express. Talk to your employer about where you can express, when, and obviously storage options too. You would need access to a fridge, of course. This will vary in different employment settings. In the UK, breastfeeding mothers do also have some legal protection under the health and safety and sex discrimination laws. Employers do have a legal obligation to health and safety protection, flexible working hours and protection from indirect sex discrimination, rest facilities and protection from harassment. Of course, there's stopping feeding, and it's your call and your baby's. So natural term breastfeeding, there is no formal set time to stop breastfeeding. It's when both mother and child mutually decide and agree to. Eskimos continue to breastfeed their children until they're 12 years old, so we know that there's both benefit and ability at that age. It's extremely rare for an infant to self-wean from the breast before a year old, and this is commonly confused with an aversion or another issue going on. If your infant attempts to wean before you're ready, ensure that you do access specialist support. However, we do know that milk teeth are also named milk teeth because they enable breastfeeding to continue. Most children do begin to lose their teeth around the 6 to 8 years old, so it would make sense that we should really be continuing till at least that age. Breastfeeding to natural term benefits both your infant and yourself, both emotionally, physically and nutritionally. It continues to be beneficial for maternal health. And breast milk changes in composition during a feed anyway, but it also changes to suit the needs of a growing infant. It continues to be a valuable source of nutrients even when your infant is developmentally ready for solids. Studies show that many immune factors passed through breast milk increase in the second year, so it's definitely beneficial at that stage too. So another term for stopping breastfeeding is involution. And again, like I've already said, it's a joint decision between mother and infant when to stop, but it is rare to naturally wean before a year old. But it doesn't mean that you can't stop breastfeeding before or even after this point. There are many options when considering weaning from the breast, as it takes approximately 6 weeks for many women to cease lactating. There is no rush in any decision. You can also wean from a breast straight to a cup if your infant's able and sit up unaided rather than introducing artificial teats. You can totally skip the bottle feeding stage. If you do stop breastfeeding suddenly, you are at risk of getting blocked ducts or mastitis. Abrupt weaning is rarely necessary, but you may choose to express rather than directly breastfeed in those circumstances, so you're still preventing blockages. Dropping one feed at a time is often suggested over a longer period of time and does seem to have less complications. But there are other ways. So there is also the don't offer, don't refuse. Here, this is when your baby's in control of when to start reducing. Not always practical if you've got other commitments such as going back to work, although it is perfectly possible to be able to incorporate either expressing or breastfeeding into a working day, but that really depends on individual situation and circumstances. But you do have employment law to take into account as well, that also protects breastfeeding. You could also gradually shorten the duration of the feed rather than the frequency, or just changing the feeding routine. So baby is totally out of sorts with what's happening, and then develops a dislike to the norm. You could change the feeding environment. So for example, if you're used to sitting on a nursing chair, you change it. So just to take away that normality for them. Or you can just distract them with other activities. I love this slide. I hear so much rubbish and old wives' tales that you really would be surprised. On a serious note though, no question is a silly one, so if you are unsure, please just ask. So some common misconceptions. You don't need to prepare your breast for breastfeeding. Nature does that one for you. Similarly, you don't need to restrict your diet in any way. You don't have to avoid chocolate or leafy greens or any of the good stuff. You can eat what you like. You don't need to eat for two during pregnancy or breastfeeding, even though you might want to. You don't need to increase your fluid intake in order to make milk. You just need to drink for thirst. You don't need to give up alcohol, tea or coffee. It's all about in moderation. You shouldn't need to give your infant any other additional fluids. If you're exclusively breastfeeding, you do not give water in hot weather before 6 months old. Formula-fed babies, it is slightly different. You don't need to use any special cream, lotions or sprays for nipple preparation in order to breastfeed. You don't need to feed to set routines, schedules, time limits, setting a clock, nothing like that unless there is a medical need. You don't need to express so that dad can bond. There are other adults that can bond in many other ways. Don't be pressurised into not feeding your baby the way you want to suit somebody else. It's your hormones here. And you don't need to bind your breast to stop milk production. Unfortunately, that's still a common practice in some countries, that when you stop breastfeeding, they wrap really quite tight, thick bandages around your breasts and around your body to prevent production, and in some countries growth as well in puberty. And you don't need to cover up during a breastfeed when in public. You have every right to feed your baby wherever you want to, and babies don't like being covered up anyway. And you don't need to drink milk to make milk. It's a totally different system. Did you know infants should sleep in the same room as their parents until they're 6 months old? This reduces their risk of SIDS because they mimic your breathing pattern and rate, and that prompts your infant to breathe too through the small volumes of CO2 that you exhale. A lot of people assume it's because they're supposed to feed until 6 months old on the breast as a minimum, and it isn't really to do with that, although it helps. So we're nearly at the end now. This is just some take-home messages, really. If you're experiencing any of the following, then please do just seek help. Pain. Pain is a sign that something's not right. Engorged breasts, hot, lumpy or painful. Nipples, whether they're damaged, any skin problems on your nipples, compressed nipples after a feed like a wedge shape, or even discoloration, they can go white or purple. Please seek help. Symptoms in your baby, also important to look at. So not coming off the breast of their own accord. They're feeding all day, every day. They are restless at the breast, sleepy at the breast, not satisfied after a feed, taking a long time to feed or a short time to feed. Frequent feeds because they're not satisfied, they're almost snacking their way through life. Infrequent feeds. Still passing meconium at day 2 to 3. Pink urates in the nappy, sign of dehydration if you remember that beautiful picture. And weight loss. This slide is really just to highlight that there is support available wherever you are in the UK. And of course, you're always welcome to contact myself either by phone, email, or join my Facebook group. Details are all here on the slide, and you can screenshot this, or as you've come through my website, it's in the header at the top. Thank you for joining this presentation. I do have a closing thought for you. As your infant's nutrient requirements change, whether it's through a deficiency, response to an illness, or environmentally influence, such as hot weather, your breast milk changes to address that specific need. This is done as their saliva communicates through your areola and sends signals to your brain in the pituitary gland and your breasts to manufacture specifically the requirement needed for your baby at that exact moment for that exact feed. Thank you.